Thank you so much, and good afternoon, everyone. And thanks for being hanging in there for a Friday afternoon talk. And I'm delighted to be here on such a beautiful day to talk to you about something near and dear to my heart, and that is the care of women with substance use disorders during pregnancy. Sorry, just trying to advance my slides. There we go. Disclosure that I work as a consultant to McKesson, but not in anything related to this talk. And I do receive royalties for the book mentioned, but will not allow me to retire anytime soon. The objectives of this talk are to recognize the scope of problem drug use during pregnancy, reflect on why women use drugs and don't get prenatal care, analyze why traditional approaches to perinatal drug addiction don't work, and apply knowledge to create a comprehensive clinic for women with substance use disorders. Start with a case presentation. This is Carla. She's a 36-year-old gravida 1 para 0, and at 25 weeks she presented to me for prenatal care. I was back when I was in private practice back in Hawaii before I became interested in addiction medicine. She stated this was an unplanned pregnancy. She had originally wanted to terminate the pregnancy, but she really found out she was too late, and now she was excited. On my routine screening, using the old ACOG form, learned she had a history of high blood pressure. She wasn't on any medications currently. And then looking at this bottom part, denied any drug, alcohol, or tobacco use on screening. Social history, she's employed as a bookkeeper in a stable 4-year relationship. Her tox screen at that time, because she had late prenatal care, and that's what I was taught to do if someone came in late for prenatal care, was negative. A week later, she presented to my office with a blood pressure of 160/110 and 2+ proteinuria. Transferred her to the hospital, and there her tox screen was positive for methamphetamines. And this is really a kind of an eye-opening moment for me because, I thought I'd done everything right in screening, and she had not disclosed use to me, and I really, do what I usually do, which is ask the residents, so what do you guys usually do? I was new to Hawaii at that point. Anyway, I was taking care of her in the hospital. She spent 5 weeks in the hospital with preeclampsia with severe features. The first 4 days she was slept and was extremely irritable when I'd come and round on her in the morning. 2 weeks into her stay, I walked in the morning to round, and she was very tearful. They're going to take my baby away, aren't they? So I was trained in New Mexico, and this just seemed a very strange thing for her to say, because in New Mexico we had the Milagro Clinic, which is a perinatal clinic that took care of all of our pregnant moms with substance use disorder. In those days, in the 90s, that was mainly heroin, and so most of them were on methadone at the time. And so I didn't have a whole lot of experience with methamphetamines, and I didn't have a whole lot of experience with child welfare, actually taking babies away. The model I was used to was much more of a harm reduction approach and keeping moms and babies safe while they're together. So I did not know what to say to her, and I asked the resident again. I'm like, so what do they usually do in this case? And he's like, well, to be honest, I think CPS is just completely overwhelmed. I don't think they know what to do. And so, yeah, they'll just probably take the baby away. And so I thought that was a very strange reaction, and it kind of spurred me to really look into, okay, so we don't have a clinic that specializes in the care of women with substance use disorder. What can we do about that? And I just joined the University of Hawaii, and as a general OB/GYN, really needed a niche. And this is, I said, well, this is something that's really needed. And having trained in New Mexico, I really identified with and really liked the Milagro patients. So that's how I got involved. And just going back to, why we think it's okay to treat someone with an addiction by punishing them. And so that's kind of understanding addiction is so important in the first place. ASAM defines as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits lead to characteristic biologic, psychologic, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. And it's just a lot of psychiatrists in the audience are very familiar with these pathways, probably way more than I am as an obstetrician. This is, though I joke that I practice gynecology. This is not something we're trained a lot in, but the dopamine pathways and virtually all rewarding substances act on dopamine. It's the one that makes us want to have sex, gives us pleasure from food, and everything else. And so when we have substances that act on the dopamine pathways, it gives us reward of motivation, pleasure, euphoria. It's also responsible for motor functioning, compulsion, and perseveration, sorry, can't pronounce it. It's Friday afternoon. It's also functions in mood, memory, processing, sleep, and cognition. That's why you have the hippocampus there and all of that. You also have the serotonin pathways. And so in Hawaii, the drug of choice was methamphetamines, and it works on both of those, dopamine and serotonin, by increasing the concentrations of these neurotransmitters in the presynaptic terminal. It also increases norepinephrine. Leading to a lot of the effects. And if you think of how that could act as a good antidepressant, you can see some of the reasons why methamphetamines might be a rewarding drug. So characteristics of addiction is an inability to consistently abstain, impairment in behavioral control, cravings, diminished recognition of significant problems with one's behavior and interpersonal relationships, the dysfunctional emotional response, and it is not just someone making poor choices. So this is something that we really need to be educating the population about, is that women or people with addiction have a brain disease, and they're not in control of this. That being said, as a disease, it is something that recovery can happen, and they need to explore the resilience and help them to recover. It's a chronic relapsing condition, just like any other chronic disease, such as asthma, high blood pressure, and diabetes. And actually, it has about the same amounts of relapse and the same success rates for treatment. So it's just that we don't often give the right treatment. We wouldn't think of someone with diabetes to tell them to not be on their medications. We tell that to women all the time when they're with their pharmacotherapy for opioid use disorder. So without treatment or engagement in recovery activities, addiction is progressive, and it can result in disability and premature death. It is, overdose was, before COVID, was the leading cause of accidental death in the United States for the last several years. This group is probably very familiar with adverse childhood experiences, and how it can lead to increases in all areas of life, and really decrease overall health. And one of the things is its role in alcohol and drug use disorders, and also unsafe sex. We know that each ACE that a person has increases their risk of drug use 2 to 4-fold. And ACEs really contribute to 1/3 to 1/2 of all cases of addiction. We also know that ACEs really result in unintended pregnancy, pregnancy complications, and fetal death, which a lot of times are blamed on the drug use itself, when really it can be a direct result of those ACEs. In our clinic population, we had a high incidence of co-occurring disorders, depression about 36%, anxiety, PTSD, and eating disorders, and personality disorders, quite a great percentage. And this really stems from really high rates of interpersonal violence. About 55% had a history of childhood abuse or neglect, and 63% had a history of current interpersonal violence. So these are women who are been traumatized and continue to be traumatized throughout their lives. And so when we have the responses that we do, and when we continue to stigmatize and arrest them and do and take their children away, we're just continuing to re-traumatize them. Some of the traditional approaches to pregnant women with a substance use disorder, really calling CPS because a woman who uses drugs is not fit to parent, and really using a urine toxicology as a kind of biomarker of poor parenting, which is really not how it should be used at all. The other approaches are your arrest her. She'll be in jail. She can't use there, and then the baby won't be affected. And then arrest her and make enrollment in drug treatment a condition of discharge, which sounds pretty humane, right, compared to the other two. The trouble with child welfare and removing children, when I was in Hawaii, the system there was every child with threatened harm was removed from the household, and threatened harm included any exposure to drugs. Even in cases where abuse or neglect was not confirmed, 15% of the children still removed from the home versus 4% nationally. So this is just from any report of drug use, not even confirmed use, not even a substance use disorder. Without any evidence of child abuse. And they found that 80% of the active child welfare cases in Hawaii were secondary to methamphetamines. The problem with child welfare and doing this is removing a child from his family may cause serious psychological damage. Talk about the ACEs. Growing up in foster care is one huge ACE there. Damage is more serious than the harm intervention was supposed to prevent. And it's also harmful for the mother. It serves a profound loss. This is a quote from one of my patients. "I want to have another baby to fill that hole in my heart from missing those 2 months." So even though she was reunited with her child, just the 2 months that she couldn't be with them left her feeling this. And we really see this. The average number of pregnancies and deliveries are much higher than the patients without addiction. They rapidly become pregnant again. And we also know that child welfare is very racially biased against BIPOC populations. Black women are no more likely to use illicit drugs during pregnancy, but are more likely to report it to child welfare. And the health and social situation of a mother involved with child protective services deteriorates after the child is taken into care. Women with a child or children in foster care were less likely to complete treatment. So we really know that keeping women and their children together, even while the woman is receiving treatment for substance use disorder, leads to better outcomes for the children and increased likelihood of success for treatment of them. Better outcomes for the children and better likelihoods of success. This is actually from Gary Johnson, who was the governor of New Mexico when I was there. And, you might remember him because he ran for president. So he's not like always on our side, but he did know this. Child welfare protocols were really, they tried to change them to make them more family friendly. And they really did the assessment, child welfare worker I talked to in about 2005, really changing based on their parents' attitudes, acknowledgement of drug use, their willingness to volunteer to participate in services. And so they're really put through all of these hoops that they had to go through to get drug treatment, follow-up medical care, parenting classes. And this can be very difficult for someone who is in early recovery without resources. And so a lot of times, you know, poverty became a big barrier to really completing all of this because they didn't have transportation or other support for the, you know, childcare for their other children, and so would lose custody. And we saw that, you know, how's this working? Another patient, despite having good prenatal care, negative tox screens throughout her pregnancy, and a place to stay, was not able to take her baby home and lost custody of her older daughter because the social worker that she was working with said she had not a good enough plan. So really, it can be very capricious and up to the social worker or the child welfare worker that's involved, and not to disparage social workers, because I love social workers, and not to disparage child welfare workers, but I think there are some out there that really have an unclear, you know, understanding of addiction and what it takes and why it's so important to keep families together. This is this patient's response. It's all so depressing, it makes me want to start using again, and can be responsible for postpartum relapse. And we know postpartum, you know, this group more than any is very, you know, I'm sad I missed Allison Stubbs' talk about the 4th trimester, but we really, one thing we're seeing is an increased risk of drug overdoses and suicide in the 4th trimester, and due to a lot of causes, you know, overdose, inadequate treatment, because they lose their access to medication for opioid use disorder, because they've lost their access to Medicaid. There's this push to have patients detox during pregnancy in order to prevent NES instead of looking at the disease from a life course perspective. And so, and a big one of this is loss of custody and its relationship to intentional and unintentional overdoses. Luckily for Carla, she had a happy ending. Despite delivering at 33 weeks by an emergency C-section for abruption, they actually both did well. Mom went home on postoperative day 3, and baby actually only stayed in the hospital a couple weeks and was able, because dad was sober and mom got treatment, they were able to maintain custody. And I got to see her at her, you know, 2 and 6 and week visits, and even 6 months later, she was continuing to do well. So I just want to say that pregnancy can really be a transformative time, but we need to make sure women and their families have support for this. The traditional approach to, you know, arrest her, then she can't use while she's in jail or prison. And unfortunately, this still happens, and it still happens here in California. So we really need to fight this for many reasons. Policies that focus on the harms of illicit drug use on the unborn child ignore the proven risks of legal substances such as alcohol and tobacco. And alcohol is by far the most serious drug, and with the most known deleterious effects. And so really, by focusing on the illicit drugs, we're really losing what we need to be talking to women about and providing support about for. We know in this case in South Carolina in 1997, Cornelia Winter was prosecuted for child abuse for using crack cocaine during a pregnancy. Her conviction was upheld. She was tested, as well as many other women, without their knowledge or consent. And after a prosecution, we found that admissions to drug treatment dropped by 80%. There was an increase in infant mortality and a 20% increase in abandoned babies. So it really didn't do any thing that it was supposed to. This is a case in Hawaii while I was there, and actually No Tie really well. She was arrested after her newborn son died. She admitted to methamphetamine use during her pregnancy. Luckily, her conviction was overturned, and she is actually sober and raising her children. But this prosecution really had a chilling effect on women obtaining prenatal care. And so we'd have women come in without any prenatal care, trying to hide their use or staying sober, you know, in order to have their toxicology, like my patient. We know women are a fast-growing proportion of the US prison population. Over 61% of women in federal prison are incarcerated for non-violent drug-related crimes. And we know that plea bargaining, which is very common, punishes those not willing to inform on others, which can be a lot of women. Conspiracy charges leads to mandatory minimum sentencing. And after any conviction, they have an inability to obtain public assistance, a job, or housing. So they're stuck in this cycle of poverty and, you know, feel like drug use and crime is all that they can really do. We also know that drug use occurs at similar rates across groups, but compared to white women, Black women are almost twice as, and Latinos are 20% more, and Native Americans are 6 times more likely to be incarcerated for drug use. So we know that this is such a problem with racial inequity, and we really need to fight this. And, you know, going back to the argument, well, at least she's not using drugs, but she's not getting adequate prenatal care. She's not getting mental health care. She's not getting substance treatment for her substance use disorder. They're subject to abuse, inadequate nutrition, increased stress, and all of which increase pregnancy complication. We also know that treatment is much cheaper than prison. And talking about burdening the foster care system, 60% of women in prison are mothers of minor children. So you have these children also going into the foster care system and kind of promulgating the ACEs for the next generation. You know, they talk about this as how to help women and babies, but it's really not. This was a case of a New Jersey woman. She became addicted to prescription drugs while she was depressed over the death of her infant. She became pregnant and at the advice of her doctor entered treatment with methadone. Her baby was born with neonatal opioid withdrawal or neonatal abstinence syndrome. The New Jersey Appellate Court ruled that this could be considered child abuse because she was taking a prescribed medication because this baby had neonatal withdrawal. So this is something, again, you know, we're having to counteract and really provide education to the community that this is a medical condition. Do we punish women who have a stillbirth for other reasons? You know, and this is not even stillbirth, sorry, that's a different case that I'll get to. This is, you know, another case that this patient had been on buprenorphine prior to the pregnancy. She weaned herself off of it, was doing fine. She didn't feel that she needed it. And yet the court then went in and made her go back on it. So it can go both ways. And we really shouldn't be policing what women do with their bodies while they're pregnant. This is the latest fiasco in Tennessee, where the legislature passed a bill that could potentially criminalize pregnancy outcomes, force pregnant women into treatment, has a potential to make a criminal out of any baby who suffers a loss or gives birth to a baby with health problems. And so if you think that's just in Tennessee, you know, there's 2 current California cases. Chelsea Baker is in jail right now and has been being held on $2 million bail. And Adora Perez is in prison, both for having stillbirths that the judge, not any medical person, blamed on using methamphetamines during pregnancy. And So National Advocates of Pregnant Women and Lynn Patrow looked at 413 criminal and civil cases where law enforcement intervened in the lives of pregnant women between 1973 and 2005. And there's been at least that many cases since then. So it's not gotten any better. As a society, do we believe that there's a point in pregnancy when women lose their civil rights? And even ACOG has come out, the fundamental concern that I have is we're criminalizing a medical problem that these women suffer from, and that we don't do that in any other segment of our society. As I was saying earlier, we don't lock up women who have a stillbirth because their diabetes is not under control. And so we shouldn't be locking up women who have this medical condition. As far as traditional approach 3, arrest her and then, or, forced treatment. This is a patient I saw in the emergency room. She had a threatened miscarriage, so she was bleeding and pregnant. I asked her how long she would be in jail. She said, until I can get into treatment, I filled out my application for Women's Way, but I may not get in because I didn't finish last time. So she had left treatment and she was worried that they wouldn't let her back in and relapsed. We know that increases motivation to get treatment, but not necessarily motivation to participate in treatment. And we also know that there's not enough treatment facilities. Only 18 states have treatment facilities specifically for pregnant and parenting women, or people, sorry. One of my patients had to get arrested before she was able to get treatment. She'd been on a waiting list for 5 weeks. Talking about underlying mental health conditions, she went off her medications for bipolar disorder, got drunk and robbed a bank. So and then she was able to get treatment. What we know is there's no evidence supporting punitive responses decrease drug use in pregnancy. It really fails to recognize the inadequacies in the healthcare system and other supportive services for pregnant women who use drugs. As I mentioned before, the capacity is inadequate. Only 15% of treatment centers offer specified services for pregnant people. Access is limited. For those in poverty, rural areas, uninsured or insured through Medicaid, it's especially hard to get treatment. Quality of treatment ranges dramatically, and there's barriers in treatment for opioid use disorder. If they need methadone, there's no methadone treatment north of Santa Rosa, I can tell you. So my patients up there have difficulty. Gender-specific treatment is extremely important for women with opioid use or with any substance use disorder. It needs to provide childcare and transportation. Really needs to be trauma-centered with the high rates of interpersonal violence and childhood sexual trauma in these patients. And because women are much more relationship oriented, they might not do as well in residential treatment, especially if they're separated from their older children, because most treatment facilities, even if they let them bring children in, usually only let them bring 1, at the most 2, and they're usually, because of regulations, younger than 5. So if they have older children, again, they're getting separated. What about, this feeling of, that patients all lie to them? Well, of course, they're going to lie if they have fear, and they have a lot of reasons to be fearful. Fear of discovery. Rightly, they are fear of being prosecuted, fear of losing their children, fear of having to go through treatment and being separated from their children, and most, finally, kind of most insidiously is their fear of disapproval from the medical care systems that are supposed to be helping them. These are actual quotes from people I worked with. I'll see that woman, I'm good at yelling at patients. This is about a patient of mine with a substance use disorder. She lied to me. I really let her have it. How dare she? And she has 3 other children at home. I hope they take them away too. This is a patient that had to come in and had a 24-week preterm delivery, and the child had, or the infant had died. And this was my colleague's response to that, because she was using methamphetamines. And we really need to remember, this is from NoFast, which is the Organization for Fetal Alcohol Syndrome, but it also applies to women who use drugs. No woman drinks because she wants to hurt her baby, or no woman uses drugs because she wants to hurt her baby. Pregnancy is just a time in the life course perspective, and it's a very beautiful time for change, but it also, you know, we need to treat it in the life course perspective and realize that no woman starts using substances when she's pregnant. We know that substance use disorders, there's several studies that have shown this, are the most stigmatized medical condition, and pregnant women with substance use disorders are even more stigmatized. And terms such as crack baby or opioid kinase victims serve to promote the stigma. We really need to remember that babies aren't born addicted, they're physically dependent. And we need to work towards a dictionary focusing on person-first language and using DSM-5 terminology. Just changing the language of addiction is so important, really, and this is something that I will harp upon to my trainees and to my partner and everything. We really need to get away from using the terms such as addict, abuser, user, junkie, druggie, alcoholic, drunk. Really using person-first language and using DSM-5 because it is a person with an addiction and a person with an alcohol use disorder, person in recovery. It's not a clean or a dirty drug test, it's a negative or positive result. And it's not, you know, and it's a substance use disorder. And even every time I talk to the press, I need to always talk to them about their language because it is so important. This is a, you know, in the Boston Globe, you know, newborns can't have addiction. Addiction is as defined above, and it really requires that they're, you know, actively taking in the substances. They are going through withdrawal because they are physically dependent on a substance. This study really points out how important language is even among healthcare providers. This is 2010. They did a study of doctoral level. They didn't do 2,000 doctoral level addiction providers. The study was in 2010. They studied addiction and mental health providers. They provided them with case scenarios of patients with legal difficulties from substance use. Half the scenarios used substance abusers and half used with a substance use disorder. The scenarios with substance abusers were significantly more likely to be judged as deserving punishment than the exact same scenarios as those having a substance use disorder. So when we humanize patients, we really, you know, think that they're less needing of punishment and more needing of treatment. So really remember to humanize. Some of the harms of stigmatization. This is a bad obstetric outcome we had in Hawaii. A patient presented to a partner of mine at a community health center at 28 weeks pregnant, and she had very bad heart failure at the time. Her ejection fraction was 10% from methamphetamine use, and my partner was trying to, at least that's what it had been in the past. And so my partner tried to get her to go to the hospital on seeing her for a first prenatal visit. And the patient says, no, I'm not gonna go. They're always so mean to me when I go there. And this patient actually had a cardiac arrest at 32 weeks. She was brought in by EMS because her partner had been doing CPR. She had an emergency C-section in the emergency room, and both she and baby ended up on life support for a week before they both had support withdrawn, and they died. So this really shows that stigma kills. We need to do better. What does work? We know that universal screening, brief intervention, education, referral, and so really having a robust system of SBIRT or screening, brief intervention, and referral to treatment is so important, as just like any other mental health condition. And the SBIRT process should be done at annual exams and new OB visits, and then with those with identified problems, they need to have follow-up at subsequent visits. And what SBIRT really is screening, which is identifying patients who need a further assessment or treatment, providing a brief intervention, and for those who need treatment, referring them. This is a pyramid that shows how universal screening should be implemented. So universal screening should not be a urine drug screen, but a brief questionnaire, an interview, or computer-assisted assessment, which then stratifies patients into risk categories. So the majority of patients, about 70%, will be in low risk, which is no past or current use, low level of use stopped prior to or immediately upon pregnancy. And this group just needs brief advice. And so people ask me, well, what if they're lying and say they're in this group? But if you're providing them brief advice and you're asking this in a open-ended, caring approach, and then readdressing it often, then it opens the channels of communication, and hopefully they will disclose later. If they have moderate risk, high use in the past, including recent treatment, stop use late in pregnancy, or continued low level of use, these are the patients that a brief intervention can be very helpful with. And this is the majority of patients that you're going to see that screen positive. And so really being familiar with motivational interviewing and really doing frequent follow-up visits with the provider. And if they are high risk, I would argue that probably any current use during the pregnancy that doesn't stop after a brief intervention or doesn't stop, upon the pregnancy, that they probably do meet criteria for substance use disorder and may need treatment. So that's kind of who does this. As far as screening tools, there are several out there. The NIDA 4 and NIDA Quick Screen is a good one, which can be followed with an audit or DAST if you need further assessment. The 4Ps Plus really can ask about family history, which can get to history of domestic violence and things like that. And then really, just talking about motivational interviewing, probably this group it's fairly familiar with it, but it can be really powerful during pregnancy for alcohol, drugs, and alcohol, tobacco, and even drug use. And so using these techniques and just a reminder of the stages of change. We're not trying to get somebody from pre-contemplation to action. We're really just trying to nudge them along this, and so that they can and hopefully be in this stage. And really just remembering that ambivalence is normal. If people want to change, they don't want to change. The whole idea of motivational interviewing is working with ambivalence and doing this decisional balance about what's good about using, what's not good about using. Really just being empathetic, supporting health efficacy, rolling with resistance. And this is really key in pregnancies, developing a discrepancy between the current behavior and future goals, because 99% of women have a future goal of a healthy pregnancy. And so if you can gently, with permission, point out how her current behavior is not consistent with that goal, that can help. The 3 tasks of a brief intervention: feedback, listen, understand, and exploring options. We're not to warn. We're not to motivate by challenging, finger wagging, warning, all of these, shaming, playing the expert. Your job is only to deliver the feedback and let the patient know where to go with it. And really want to find a hook, asking the client about their concerns, providing non-judgmental feedback and information, watching for signs of discomfort with the status quo or interest in ability to change, asking the question, what role do you think alcohol, smoking, drug use played in your problems, and let the patient decide. Rolling with resistance. I'm not going to push you to change anything you don't want to do, and what you do is up to you. The readiness rule and the importance and competence rules. And then the 3rd task, options for change, a menu of change options. And these are just some examples of things you can do. So this is the clinic that I started in Hawaii, the PATH clinic, and they are still, I'm not there anymore, but they're still housed in a acute house on the grounds of the Salvation Army Family Treatment Center. So we were able to have a therapeutic garden and literally a kitchen and things like that. Our mission is to provide comprehensive perinatal clinic and social services to women with past or present substances. And to change the wording, this was written in 2007, so the wording is obsolete. In a home-like setting, free of judgment, and support of each woman's unique path from pregnancy to capable parent. And we really started it on using harm reduction principles, and it's this set of practical strategies and ideas to reduce the negative consequences associated with drug use. And I think most obstetricians are really familiar with harm reduction. You know, women get pregnant with all sorts of medical issues, and we're very good at helping them have healthy pregnancies despite that. But that being said, harm reduction in pregnancy was kind of not well described in the US. But there's programs in British Columbia, the Sheway program, and others have really robust programs. And so the things you can really make a difference are improving nutrition, decreasing smoking, decreasing alcohol, drug use, encouraging breastfeeding, promoting dental health, encouraging physical activity, encouraging early and continuing prenatal care, and promoting social and community support. These are some of the services we offered, and just talking about contingency management, because it's one of the most successful treatment modalities, especially for stimulant use disorder where there's no medications. And we had a program that was funded by the March of Dimes, where we reward women for coming in for prenatal visits, having biopsychosocial evaluations, group attendance, etc. We did not reward them for negative urine toxicology, because you know, urine toxicology is fraught with difficulties during pregnancy, which is a topic for another talk. But we had very good success, and you know, our preterm delivery rates were actually equal to the state average, despite the fact that 57% of women had illicit drug use during the pregnancy, and 81% smoked cigarettes. So the only thing that was higher than the state average was low birth weight. You know, our preterm delivery rate was phenomenal, and what we really showed is that reinforced a study done in cocaine-exposed pregnancies that prenatal care ameliorates drug usage. Some unexpected successes: 87% significantly decreased use, and most became abstinence. Women who had lost custody of their other children due to substance use were now sober, parenting their babies. 95% of our patients maintained custody at 8 weeks. And those who maintained custody sought long-term birth control and job training. And so our repeat pregnancy rate was very low. So in summary, women don't choose to use drugs when pregnant. They are addicted and then become pregnant. So it's part of the life course perspective that we really need to look at. And the policies that punish women for drug use in pregnancy, they're counterproductive and serve to really prevent women from obtaining care. And prenatal care and other harm reduction means are effective at preventing complications from perinatal drug use. Open up for questions. Thank you.
Thank you, Dr. Wright. I have quite a few questions here, and I just want to remind the audience that this is your opportunity to share your questions via the question and answer function at the bottom of the screen. First, Dr. Wright, I have a question. Can you give more context for where and how women are arrested for substance use in pregnancy? Is this in the hospital setting or outpatient setting, or are they brought in by ambulance and already restrained?
I can answer that. We had a case recently that a patient was arrested in the hospital so So that still happens in this state, in this county, for example. And I'm not sure, I need to look at where Chelsea Baker was arrested, but I believe it was also in the hospital after suffering this stillbirth. So as physicians, I find this just so egregious because, talk about violating, our oaths and protecting patients.
So I also have two comments here, wanting to let the audience know that there is now methadone treatment north of Santa Rosa. Humboldt County is doing a good job, and there is a clinic in Eureka now.
Great, awesome. How close is that to Lake County? Because that's where I was looking.
Okay, and then I also have another question. How do you balance harm reduction and risk assessment? I can imagine there are more choices during pregnancy, but in postpartum period, how do you balance the needs and health of the mother and the baby?
Well, I think I think it's a false dichotomy to think of them as separate. We have this idea that we just need to protect the baby at all costs, but we really, by keeping mom and supporting mom, the best thing for a healthy infant and child is a healthy mom. So really, there shouldn't be a false dichotomy. It should be a dyad. We should be providing the care to both of them together.
And I have a couple questions here. Can you comment on resources for pregnant women in the Bay Area for treatment of substance use?
So there's a couple of residential treatment centers that I know of. I'm relatively new here. I've been here just over a year, so I'm still learning them. But I know Health Right 360 has a program, Epiphany House, things like that. So there are some excellent treatment facilities around, and I'm working on trying to get, Team Lily at San Francisco General has great prenatal care, and we're trying to start a similar program at UCSF hospitals.
Here's another question. I often see perinatal patients that are marijuana users. They know they want to stop, but they can't. We would talk to them about harm reduction, but we never get them to stop. Serious ambivalence is prevalent. Any other ideas?
I mean, I think just, unfortunately, there's no medication for cannabis use and cannabis use disorder. There is a lot of ambivalence out there because there's so much misinformation that just because it's herbal and natural means it's safe. So, continuing to really explore that ambivalence, there's a new study that came out that shows possibly increased risk of psychosis in their children. So I think at that point, you can ask with permission to explore the risks and let them know we're learning more and more about, the cannabis during pregnancy is probably not a good idea, and offering them treatment if they're having trouble stopping.
Another question, how do you address healthcare providers who are biased against mothers with substance abuse disorders in the hospital setting? How can we become more compassionate and humanize them without wanting them to immediately stop using and, quote, take care of her baby?
That's a great question because I'm laughing because I'm right in the middle of addressing this at my own hospital. I've been dealing with this for many, many years. I think just talking to them is, and hopefully giving talks like this, really pointing out that the majority of women with substance use disorders are victims themselves. And so, and really we need to be providing better education from the very beginning in medical school, in nursing school, and that this is not a moral failing. This is a brain disease, and we can provide treatment. And if we provide social support, the outcomes can be good.
So I have more than one question asking you to address pregnancy and breastfeeding, particularly breastfeeding with substance use.
So we definitely want to encourage breastfeeding for women who are in recovery from substance use, especially if they're on medication for the treatment of opioid use disorder, because it really helps prevent needing medication for neonatal withdrawal. That being said, if they're actively continuing to use, especially stimulants, it's probably not safe. Cannabis is, the idea, it is transferred in breast milk and can remain there for a while. So what we don't want to prohibit women using cannabis from breastfeeding, but we want to make sure they understand the risk and really recommend that they not use cannabis while they're breastfeeding. If they are, and it's, with stimulants, that probably is contraindicated. So just providing the information, and the majority of women with substance use disorders don't breastfeed. So actually, especially opioid use disorders. So it's more that we want to encourage breastfeeding because it can be a good tool for relapse prevention also.